So let's start a discussion about today's topic. That's about the varicose veins. This is one of the very important venous disorder and most common venous disorder which is being manifested, and generally most are the patients who are coming to the surgical department are particularly of these varicosities. And let's first of all to know about the varicosities, how they are being produced. You should go back into the venous anatomy of the lower limb, but actually let me define varicosities for you. Varicose veins are basically the dilated tortuous veins which are located in which they can be located anywhere, but if we talk about the lower limb, so basically these are the dilated tortuous superficial veins which are located in the lower limbs. Particularly for that, you have to know about the venous anatomy of the lower limb. So we will be discussing about the venous system. So the venous system of the lower limb comprises of superficial venous network and the dorsal venous and the deep dorsal venous network of the lower limb. In case of the deep veins, we have the common femoral vein, we have the superficial femoral vein, we have the popliteal vein, and then we have the anterior tibial veins. Basically, starting from here, you can appreciate in this diagram that this is basically the venous anatomy. You can see here, these are the peroneal vein, posterior tibial veins, and the anterior tibial veins. These veins are actually formed by the dorsal arch, lateral and the medial dorsal arches of the foot. They're coming down, deep down from here, the dorsal arch or the dorsal venous network of the foot. That's actually coming, they converge to each other and they form the anterior posterior tibial veins and the peroneal veins. You can see here in the diagram that this is the peroneal vein, posterior tibial vein, and the anterior tibial vein. They usually paired it together and they join together to form the popliteal vein. And then this popliteal vein goes deep down. This popliteal vein is located in the popliteal fossa, and then this vein continue and just below the inguinal ligament at the anterior superior iliac spine at the pubic tubercle midway, just below the inguinal ligament, this popliteal vein is actually converted into the femoral vein. We have the superficial femoral vein. It also gives a branch which is called the profunda femoral vein, and this is the common femoral vein. You can see here this is saphenofemoral junction. Here we have the sphenopopliteal junction, and here we have the saphenofemoral junction, in which basically the superficial and the deep veins, they're connected to each other. And you can see here that we know that the small saphenous vein, which is a superficial vein that joins the popliteal vein, and then we know that the greater saphenous vein or the long saphenous vein that joins the femoral vein. The junction of the popliteal vein and the short saphenous vein, that is called as saphenopopliteal junction, right here in the popliteal fossa. And the junction of the saphenofemoral, like the saphenous, long saphenous vein and the femoral vein, just below the inguinal ligament, that's called as a saphenofemoral junction. So these junctions are very much important. I will tell you later in the lecture what is the significance of these saphenofemoral and the saphenopopliteal junction. So far we have been discussing about the deep venous system of the lower limb. Particularly, we know that we have three main veins which are coming: anterior tibial vein, posterior tibial vein, and the peroneal vein, which is formed by the dorsal network of the basically dorsal network of the foot. And they goes down, they form the popliteal vein, and the popliteal vein just behind the inguinal ligament that forms the femoral vein. So this was about the deep veins of the lower limb. Let's just talk about the superficial venous network as well. You can see here, actually this is a long great saphenous vein, which is also called as a long saphenous vein or the great saphenous vein. Great saphenous vein is located just superficially And you can see here we have the posterior medial thigh tributary as well. It's giving many of the branches. This is the saphenofemoral junction, which is the saphenous vein is draining into the femoral vein. And this is a great saphenous vein with its tributaries. You can see here there are 5 tributaries of the great saphenous vein. This is posterior medial thigh tributary. This is anterior saphenous vein. This is anterior tributary of the leg. And if you talk about the small saphenous vein, so here is the saphenopopliteal junction, in which the small saphenous vein or the short saphenous vein is actually draining into the popliteal vein in the popliteal fossa. You can see here this is the small saphenous vein. This is a more better visual image available for you guys. You can see here that this is the anterior tibial, this is and anterior tibial, posterior tibial, and peroneal, and this is actually the dorsal venous arches, and they're forming the superficial venous network. You can see here this is another arch which is forming this short saphenous vein, which is located more posterolateral, and the great saphenous vein, which is located most medially. And you can see here this is the long saphenous, which is medially, and this is the short saphenous, which is actually located most laterally. So you can say that these actually anterior tibial, posterior tibial, and the peroneal, they are actually coming up and joining up, and they're forming the popliteal vein, and the popliteal vein then draining into the femoral vein, and then the femoral vein is forming up the common iliac vein. It is draining into the common iliac vein. But here the lateral dorsal arch and the medial dorsal arch, actually the medial dorsal arch is forming the long saphenous or the great saphenous vein, which is running just on the medial malleolus, and the lateral saphenous or the lateral dorsal venous arch, it's running on the lateral aspect and the lateral malleolus, and it's actually forming the short saphenous or the small saphenous vein. The saphenous vein enters into the popliteal fossa, drains into the popliteal vein, and the long saphenous vein, along with the saphenous nerve, it goes from the saphenous opening, and behind the inguinal ligament it drains into the femoral vein. Sural nerve is the nerve which is running more laterally along with the short saphenous, and the saphenous nerve is the nerve which is running along the long saphenous vein. Extensive anastomosis, which is present in the foot basically, or they interconnect the veins of the ankle and the foot. Actually, they form the fibular and anterior tibial, and together with the posterior tibial, they drain into the popliteal as well. Already told you this is basically the deep system, which is extensive anastomosis present in the foot. They combine together, they make the anterior tibial, posterior tibial, fibular or peroneal. Fibular and peroneal, this is the name of the same artery with the two different names. It's the same artery but with the two different names, right? So fibular, posterior tibial, or anterior tibial, they drain together and they form the popliteal, and the popliteal then drains into the femoral vein. You can appreciate in the picture, and the femoral vein then drains into the external iliac veins. This whole is the basically this whole is a deep system of the lower limb. But if we talk about the superficial, you can see here you have the small saphenous, you have the great saphenous. This small saphenous actually collects the blood from the superficial veins of the leg and the foot and drains into the popliteal, and the great saphenous, which is running more medially along with the saphenous nerve, it collects the blood from the superficial veins of the lower limb and it drains into the femoral, and ultimately this femoral drains into the external iliac. Now let me tell you that superficial and the deep venous network, they connected to each other through the perforators, and there are 3 perforators which are located in the lower limb. The first perforator, which is located in the inferior 1/3 of the thigh, is called as Dodd's perforator, and the second perforator, which is located just the anterior aspect of the leg, that is called as Boyd perforator, and another perforator which is called as Cockett's perforator, that is located deep down in the anterior 2/3 of the leg in the gator region. So these are the perforator which are basically connecting the superficial veins to the deep veins. Now, what is the function? We know that the superficial venous network, they will all drain into the deep venous network, and we know that the deep veins, they will carry this popliteal, then femoral, then external iliac, then common iliac to the inferior vena cava, and through the inferior vena cava, the blood will goes to the right atrium of the heart, and then it goes to the lungs for the oxygenation, and then the blood returns back to the heart, and then the heart actually circulates this oxygenated blood to the body again. Talking about the venous pathophysiology of the these varicosities, how basically they are generated, the most important thing is a venous hypertension. Now let me explain you this mechanism actually, that the arteries, they have more of the pressures in them. We know that the arteries at the arterial end, the blood pressure is about 32 millimeters of mercury. At the capillary end, the pressure is about 12 millimeters of the mercury, and in the main vein, the pressure is about 5 millimeters of mercury. Now, what happens is, we know that almost whenever the patient is in a standing position, then the pressure which is in the deep veins, that should be equal to the column of the heart extending from the surface of the heart, and the pressure should be around 100 millimeters of mercury. We know that the blood is moving against the gravity. That's the blood has to move against the gravity from the deep down to the, because heart is located more proximally and the veins are located distally in the inferiorly. So the blood has to move from downside to upside, and for that, against the gravity, the pressure has to be built up. So there are two mechanisms which are very much important. First is the process of the inspiration, in which the intrathoracic pressure is the intrathoracic pressure is decreased. The decrease in the intrathoracic pressure and increase in the intrathoracic volume, plus the contraction of the calf muscles. These two phenomena are very much important because they increases the pressure in the veins. And that's how the blood moves from superficial veins to the perforator into the deep veins, and then the deep veins carry this high pressure blood into the heart, because the pressure in the heart is 100 millimeters of mercury, in the aorta is 100 millimeters of mercury. So the pressure in the lower legs should be more than 100. It should be around 200 and 300 millimeters. So the pressure gradient should be created, and the blood and the pressure should be from the movement of the blood should be from the higher pressure to the lower pressure. That is from downside to upside, from the lower limbs to the heart, right? So that's why this is very much important, and the phenomena which is responsible for this is the number one is the decrease in the intrathoracic pressure during inspiration, and second is the contraction of the calf muscles. So you can see here, this diagram is explaining a little bit of the phenomena which I have already explained to you guys. The pressure has to be built up here so that the blood has to move from downside to upside, and the blood should be drained. This is the graphical representation. In standing, what happens is the pressure has to be increased, and the pressure but sometimes there are incompetency in the valves, or there is incompetency in the contraction of the calf muscles. Because of that, the pressure is not generated that much. If you could see here in the normal limb, the pressure is generated and then it goes down, and then while walking the pressure is low, but whenever in the standing position against the gravity, the blood has to be moved up, and that has to be built up to at least 80 or 90 millimeters of mercury or 100 millimeters of mercury. But in case of the post-thrombotic limb, there's a difference, and you can see the pressure gradient has to be increased so much, so that will lead to the formation of the venous hypertension. This is another graphical representation, and these are the four factors: hormonal venous dilatation, deep vein thrombosis, thrombophlebitis, and pelvic obstruction. These four things will lead to the valvular incompetence, and plus the effect of the gravity and also the effect of the AV malformations. This will lead to the high pressure which is being transmitted to the superficial veins, and because of the development of the high pressure, obviously there would be varicosities, dilated tortuous channels, they will be formed, and a high pressure transmitted to the cutaneous venules, and that will lead to the high capillary permeability, that will lead to the interstitial edema and also the extravasated RBCs. So this is basically the venous pathophysiology. Whenever there is a hormonal venous dilatation, there's a valvular incompetence, there's a DVT, which is deep vein thrombosis, thrombophlebitis, or pelvic obstruction. These all things will lead to the valvular incompetence. Whenever there is a valvular incompetence, the blood will not be able to flow from superficial veins to the deep veins, and there would be backward flow of the blood from deep to the superficial, and the high pressure would be transmitted to the superficial veins, and this high pressure in the superficial vein will cause the dilatation and tortuous veins on the superficial skin surface, and this then high pressure will be transmitted to the cutaneous venules. There would be high capillary permeability that will lead to the interstitial edema, and there would be extravasation of the RBCs as well. So about the clinical features of the venous hypertension includes the varicose veins, telangiectasia. As you can see in this diagram, there are multiple dilated, small, superficial skin veins. These are called as telangiectasia. There can be saphenofemoral as well. There can be basically, this is actually, again, you can see here the small dilated channels. You can see here. Then you have edema as well, because accompanying that there can be DVT, there can be eczema, there can be skin pigmentation. As compared, you can see here in this diagram that basically there are two limbs. This is a normal limb, and if you compare this with the other side, this is more pigmentation. And also there can be lipodermatosclerosis, which is basically the hardening of the skin, and you can appreciate here in the diagram there's whitish patches, hard and thickened skin, which is called as lipodermatosclerosis. And this sign is also called as inverted champagne bottle, because sometimes there is from above, if you go from above downward, the skin is very much thickened, and there is a trophy of the musculature as well, just along this. So it's just like the appearance is like the inverted champagne bottle. So lipodermatosclerosis is also called as inverted champagne because of the physical appearance, and from above the skin is swollen, dilated, and from downwards there is trophy due to the lipodermatosclerosis. There can be atrophic blanch, you can see here, and there can be venous ulcer as well, because venous hypertension leads to the formation of the venous ulcers as well. So this was about the clinical features. There is a classification system which is very much important when we are discussing about the varicosities, which is a CEAP classification, which is C stands for clinical, E for the etiology, A for the anatomical position, and P for the pathology. C0, that means there is no signs of the venous disease. C1 means there are small telangiectasias or the reticular veins, you can see here in the diagram. And C2 is basically the varicose veins, right? So C0, no signs of the venous disease. C1, small telangiectasias or reticular veins. C2 is about the full development, full-blown varicosities. And C3 is edematous limb. C4A is pigmentation or eczema. C4B is lipodermatosclerosis, or there are multiple atrophy blanch which are also present beside that. And C5 is healed chronic ulcer. So you can see here C0, no signs of the venous disease. 1 is about the formation of the telangiectasias and reticular veins. C2 is varicose vein. C3 is edematous limb. C4A is pigmentation or eczema. And C4B is lipodermatosclerosis or atrophic blanch, and C5 is healed venous ulcer. You can see here in the diagram. Plus there's also swollen or edematous limb as well, and C6 is active venous ulcer. C5 is healed venous ulcer, and C6 is active venous ulcer. So this was about the clinical presentation of the limb which is actually undergoing the venous hypertension. The second point in the CEAP classification is actually E stands for etiology. Etiology can be congenital. There can be congenital deformity like collagen deficiencies, collagen vascular diseases, Marfan syndrome, Allen-Dallas syndrome. So this is basically EP is a primary and ES is secondary. EP is primary, like the primary change is in the primary disorder is in the veins, and E is secondary to thrombosis, like first of all there is a DVT, and then ultimately the DVT, because of the superficial, because of the deep thrombus which is present in the deep veins, that causing the pressure to be transmitted backward into the superficial veins. So EP primarily and ES is secondarily. EP primarily means there is no DVT, there is no thrombus, and the superficial veins, the main pathology or the varicosities are in the superficial veins, and there's no post thrombotic complication, right? And ES is secondarily to the post thrombosis. So these are the etiological classification, and EN is no venous cause identified, and you have to move for the anatomical classification, right? If we talk about the A part of the CEAP classification, this is basically AS, which is for the superficial veins, AP for the perforators, and then you have the AD, which is for the deep veins, and AN for no venous location. First of all, we discussed about the clinical classification, which was C0 to C6. Then we talk about the etiological classification, which was basically hereditary or congenital, and then moving on to the primarily and the secondarily causes. And then we have been moving to the anatomical classification, which is AS is for the superficial veins, AP is for the perforator veins, AD is for the D veins. Like maybe the incompetency can involve the superficial veins. The incompetency, the valve incompetence can be in the perforators, and AD is in the deep veins, and AN is basically no venous location which is being identified. Now if we talk about the pathological classification, we have PR, which is basically the reflux from deep veins to the superficial veins, PO, which is obstruction, secondarily to the thrombotic event, which is located in the deep veins, and there is PRPO classification, which involves that we have reflux and the obstruction as well. The most common cause, because this venous hypertension leads to the reflux, and subsequently if there's also obstruction, like if there's a thrombus which is located in the deep veins, the thrombus actually causes the hindrance, and there's obstruction to the flow from superficial to the deep veins. Plus, because of that obstruction, the blood can flow backward from deep veins to the superficial veins, causing the dilatation and the tortuosity of the veins. So P or PO, it involves the reflux and obstruction as well. So this was about the CEAP classification, which is very much important whenever you're discussing the venous disorders, formation of leg ulcers or varicosities, because involving superficial thrombophlebitis or the lipodermatosclerosis, eczematous changes, those are important. So clinical, etiological, anatomical, and pathological classification. This is widely accepted and widely followed classification for the varicose veins, and we know that PN is for the no venous pathophysiology identifiable. Now, this is again explaining the same thing. This is a normal blood flow. You can see here, normal vein. These are the valves, and these valves are very much competent. And because of these valves, there is basically no backflow. There's no reflux. But you can see here, if the valves are not very competent, they're deformed. You can see here there would be abnormal blood flow, and the blood will be pulled back. There would be reflux of the blood, and that will lead to the dilatation. And because of that dilatation, there would be skin bulging, and you can see here the thin wall of the vein as well. So this is the basic concept in the formation of the varicosities because of these valve incompetence or collagen deficiencies or incompetence of the cough perforators, actually the blood will not be able to follow a retrograde flow. And you can see here that obviously it won't be able to follow anterograde flow of the blood. Instead it will follow a retrograde phenomena, and because of that deformed valve, there will be abnormal blood flow, there will be backflow of the blood, leading to the dilatation of the vein. So this is basic pathophysiology of the varicose veins. Now, what are the symptoms of the varicose veins? Already almost all the clinical features. Patient can complain about the aching and heaviness. He can complain about the throbbing nature of the pain. He can say that he's suffering from burning or busting sensations. There can be itching because of the skin changes, and there can be telangiectasia because in these varicosities, different kinds of the inflammatory cytokines as well, they're also released because they cause the itching. Then there can be telangiectasias, and you can have the radicular veins. Plus there can be these are the symptoms. Patient will complain about aching, heaviness, throbbing pain, burning, itching. He will tell you about the skin changes and radicular veins if he can appreciate. The signs which we have to look in a patient with a varicosities is basically we have to look for the skin changes. We have to look for the ulceration, if there are any ulcerations present. We have to look for the eczematous changes, atrophic blanche. We have to look for the lipodermatosclerosis. And you can see here, this is medial thigh and the calf varicosities, and there is basically great saphenous vein incompetence, and in the posterior lateral wall there is a small saphenous vein. We know that most of the time the distribution of the great saphenous vein is along the medial aspect of the thigh, and the small saphenous vein is on the lateral aspect of the thigh. So if the location or you have the varicosities on the medial aspect, most of the time there is a great saphenous valve incompetence. And if it is in the lateral aspect or the posterior lateral calf muscles, actually the incompetence is in the small saphenous or the short saphenous vein, right? And sometimes if there's an anterolateral and the calf varicosities, anterior and the lateral as well, they can be isolated incompetence of the anterior saphenous vein, which is a tributary of the great saphenous vein, right? If we talk about the investigation of the varicosities, the most important thing is, first of all, you have to go for the ankle brachial pressure index, which is the highest systolic pressure in the ankles divided by the highest systolic pressure in the brachial artery. Basically, it tells you about the peripheral blood which is present. You have to identify the ankle pressure brachial index. If it's normal, that means if it's abnormal, that means actually there's an incompetence in the arterial system, not in the venous system. So we do the ankle pressure brachial index to rule out the arterial pathology. It's not very much diagnostic about the venous disorder, but it will help you differentiate between the arterial and the venous disorder, right? So most of the time, if the ankle pressure brachial index is normal, we will think about the venous pathology, and if it's abnormal, we'll think about the arterial insufficiency or arterial disorder. Other than that, the investigations which include is basically the Doppler ultrasound of the lower limb veins, which actually this is the Doppler ultrasound. You can see here, this is the venous flow, which actually you can see the blue in color, and the arterial flow, which is red in color. And these are the imperforators, and you can look if the flow is from the superficial veins, then perforators in the deep vein. That means there is no incompetency. And if there is, the color Doppler is showing you the retrograde travel of the blood from the deep to the superficial vein, then obviously the pathophysiology or the pathology is in the incompetence is in the deep or the superficial veins. You can see here You can, in this diagram as well, this is contrast venography. You give an inject and contrast into the veins, and you can then visualize it on the MR. So this is MR venography as well. And you can see here, this is basically, you can see the flow in the great saphenous vein. You can see the flow in the small saphenous vein. You can look up for the perforators as well. And through the color Doppler ultrasonography, duplex ultrasonography, and then you can also order for the contrast venography or MR venography. So this was about the investigation. Now, how you are going to investigate, particularly for the varicosities or the dilated tortuous veins. Now, if we talk about the management of the varicosities, first and the most easiest thing to do is to provide the patient with the compression stockings, because actually it helps to maintain the pressure, right? And it's distribute the pressure equally. You can see here, these are the compression stockings, below knee stockings as well, and you have the if the incompetence is in the saphenopopliteal junction, the below knee stockings, they are sufficient. And if it's involving the saphenofemoral and the popliteal junction, both of them, then it should be up to the mid thigh, depending upon the British classification of the stocking pressure. The class 1 stocking, this involves the pressure of 14 to 17, class 2 for the pressure of 18 to 24 millimeters of mercury, and class 3 for a pressure of about 25 to 35 millimeters of mercury. Then there can be, if we talk about the surgical manifestations or surgical procedures we have available for the management of the varicosities, is the endothermal ablation. You can see here, actually, in the endothermal ablation, what you do is you put an endoscope and you cauterize the imperforators here. You can see here, you try to ablate the incompetency which is present in the valve. So this is the endothermal ablation. You can see here in the diagram as well. Sometimes you can perform this ablation through the endoscope, and sometimes you have to put in the laser for this. This was the incompetency, and after putting the laser ablation, this is ultrasound guided laser ablation, right? And there can be radiofrequency ablation, but these are particularly less commonly practiced management strategies we have available. They're also non-endothermal, non-tumescent ablation as well. But the most common, I would be talking more about the ultrasound guided form sclerotherapy. This is the procedure which is very much similar to the procedure we use for the treatment of the second degree hemorrhoid, which is basically the injection sclerotherapy. You have to inject the sclerosing agent, which can be alcohol and phenol and almonyl combination, and you have to inject that into the vein. So this is ultrasound guided form sclerotherapy, in which you have to put the ultrasound probe. You can see here, this is the ultrasound probe over the vein. You have to identify the incompetence, whether it's in the perforator, in the superficial vein, or in the deep vein, and then you have to inject the sclerosing agent into that dilated tortuous varicose veins, which is actually sclerose that particular vein. So this was about the ultrasound guided form sclerotherapy. The other procedure which can be used for the treatment of the varicose veins is catheter-directed sclerotherapy and mechanochemical ablation, in which actually, instead of using the cannula and inserting the sclerosing agent through that cannula, you have to insert a long catheter into the vein, because if you are performing the ultrasound guided sclerotherapy, and if the pathway is very long, you have to use the catheter. So that's called as the catheter directed sclerotherapy. You can see here, this is the long guide wire, this is the catheter, and you insert through the skin and you perform the catheter directed sclerotherapy. The sclerotherapic agent is injected through that needle or the catheter, and then it will sclerose the whole of the pathway of the dilated tortuous varicose vein. The other is also the use of the endogenous glue, but actually this is not very much common, and it's not very widely accepted. It's one of the method which can be used. Actually, you have to inject the endovenous glue. You identify, you have to get into the vein through the ultrasound guided, and then you have to shot the glue into the vein. You have to go inside the vein. This is not very common, but one of the treatment modality that can be used. Most common surgery for the varicose vein is open surgery. You actually, what you do is you under the observation, maybe it can be, first of all, you do the ultrasound, you identify the perforator, you mark the perforators, and then you have to perform the open surgery. You have to give a nick, you have to go inside the vein, identify the vein first of all, then you have to tie all ligates and tie all the tributaries, so the great saphenous vein. You have to reach to the saphenopopliteal junction. You have to reach to the saphenofemoral junction, depending upon the incompetence. If the saphenopopliteal junction is identified and it's competent, and the saphenofemoral junction is identified and competent, then you have to do a minimal surgery. But if the saphenopopliteal junction is compromised, you have to go down up to the saphenopopliteal or saphenofemoral junction, depending upon the incompetence, and then you have to tie and ligate all the tributaries of the popliteal and the tributaries of the small saphenous vein and the great saphenous vein, and then you have to do the stripping. So most common surgery is saphenofemoral ligation and the great saphenous vein stripping, which is being shown. You can see here, this is a femoral vein. You identify the femoral vein, you ligate the femoral vein. This is the point of the division in which basically the saphenofemoral junction is there. Saphenous vein is draining into the femoral vein. You tie the femoral vein, you tie the tributaries, and then you ligate. And then this is the point, you ligate this, and this is the point of the division. You can see in the diagram, and here is a long saphenous vein. And the other thing is about the saphenopopliteal junction ligation, and you have to mark the perforators here as it's being marked on the guidance of the ultrasonography. You can see here, this is the junction, you have to mark them, and you have to do the saphenopopliteal junction ligation, and then you have to perform the small saphenous vein stripping. Another surgical technique which is being available for the varicosities is adjunctive surgical technique, phlebectomy, in which you actually, what you do is you identify the vein, you pull the vein outside, and then you cut it down, you ligate it, and then you recreate that anastomotic channel. This is called as adjunctive surgical phlebectomy. So this is one of the procedure which can be used. There's another procedure which is called the perforator ligation. I have already told you that in case of the lower limbs, there are three perforators: Dodd's perforator, Boyd's perforator, and the Cockett perforator. So in case of the perforator incompetency, you actually perform the perforator ligation, which is just similar to the saphenofemoral and saphenopopliteal junction ligation. You actually identify the perforator, you ligate it, and then you separate it from the rest, and then you at the end you perform the stripping. You can see here, this is a superficial vein, and this is a deep vein, and this is about the perforator, and you put the endoscope and you perform the endovascular perforator ligation. You can see here, these are the perforating veins. So we know that every surgery has got some of the complications, and for all the procedures, every procedure has different complications, but generally the standard surgery which we perform for the varicosities is most of the time saphenofemoral junction ligation with the great saphenous vein stripping, and saphenopopliteal junction ligation with the small saphenous vein stripping. So the complications in this case would be for most of the time the wound infections. They're the most common causes because after surgery, the skin is exposed, and there are different kind of you use different different sutures for that. And if there is a foreign body, or the suture is not placed accurately or approximately, that can, or the patient is diabetic or hypertensive, that can lead to the wound infections. And the other complication which can be possible in a standard varicose vein surgery is saphenous nerve neuralgia. And we know that the great saphenous vein is actually running more medially, and the small saphenous vein or the short saphenous vein is running laterally. So in case of the lateral, in case of the lateral side, and if you're performing the surgery on the small saphenous vein, it can lead to the it can lead to the sural nerve damage. And in case of the medial great saphenous vein, along with the great saphenous vein, we have the saphenous nerve. So those surgeries which we are performing on the great saphenous vein on more medial aspect of the leg and thigh, that will lead to the saphenous nerve neuralgia. And in case of the surgeries which we are performing on the lateral aspect involving the small saphenous vein, that can lead to the sural nerve neuropraxia or neuralgia. And other injury which can be encountered in case of the standard varicose vein surgery is the common peroneal injury, because common peroneal nerve is also in a close proximity to the popliteal vein, so that can lead to the injury to the common peroneal nerve. And there can be venous thromboembolic complication, because most of the time all the surgeries which are involving the varicosities, that lead to the immobility of the leg. And because of that, if you do not put the patient on anticoagulants or warfarin or antiplatelets or vitamin K antagonist, or you do not start prophylactic heparin, that will lead to the formation of the DVT, and ultimately the DVT will turn into pulmonary embolism. This is the most common cause of the death in all those surgeries which are involving whether the limbs or like the orthopedic surgery, are the surgeries which are related to the varicosities. So if we talk about these complications, they can be wound infection, they can be saphenous nerve neuralgia, sural nerve neuropyrexia, common peroneal nerve injury, and venous thromboembolic complication. So this was about today's topic, and we try to summarize this topic in a more precise form. Particularly, we talk about, in this particular lecture, we talk about the formation of the varicosities. We talk about a little bit about the venous anatomy, like the superficial venous network and the deep venous network and the perforators. The incompetence can be in the perforators and the superficial veins and the valves of the deep veins, and ultimately there would be retrograde flow from deep vein to superficial veins, and that will lead to the dilated tortuous vein. So main pathophysiology in the varicosities is the venous hypertension, and venous hypertension can be because of obstruction secondary to the thrombotic event, or because of the reflux, because of the incompetence of the valves. So these are the most important things you have to keep in mind about the pathophysiology of the varicose veins. Then we also talk about the diagnosis. We have talked about the CEAP classification, which was clinical, etiological, anatomical, and pathological classification. And then we also talk about the particularly about the manifestation, clinical features. The patient can present to you with the aching, throbbing pain, with the itching, telangiectasias. There can be DVT along with that, and there can be some venous ulcers. For the diagnosis of the varicose vein, most common is first of all, you need to perform the ankle brachial pressure index to separate it from the arterial disorders. In case of if there is ABPI, ankle brachial pressure index is normal, you'll think about the venous etiology of particular presentation, like the ulcer or the telangiectasia, also lipodermatosclerosis, and the skin changes as well. And for other more to be more specific in the diagnosis of the varicose vein, you have to order for the color Doppler ultrasonography. You have to look for the flow, anterograde flow of the vein, or of the blood in the vein, or the retrograde flow of the blood in the vein, and color Doppler is very much helpful. Beside that, you can order for the MR venography or the contrast venography, and you can identify the hole. But first and foremost thing you have to do in a patient who's coming to you with a varicosities is the compression stocking, and depending upon the compression stocking, depending upon the saphenopopliteal junction incompetence or saphenofemoral junction incompetence. So this is the thing you have to keep in mind. And at the end, we also discuss about the treatment modalities like the surgical options, endothermal ablations, and open surgeries involving the stripping methods, and saphenofemoral and the saphenopopliteal junction ligation. So this is the end of the lecture, and I hope I was quite understandable for you in this particular lecture. And thank you for watching sqadia.com. We'll bring another lecture next time. Thank you for that.